Hip replacement, I should say firstly, is an extremely effective operation for the relief of pain. It's probably one of the best operations that I do, and one of the top 3 operations of the 20th century. So after cataracts and probably open heart surgery, hip replacement in terms of restoring quality of life and relieving pain is an extremely effective operation. Mainly the indication for hip replacement is therefore pain. So typically the pain that you have with a hip arthritis is in your groin, and it can actually radiate all the way down to your knee. So sometimes it's not uncommon to see people who are presenting with knee pain where the pain is actually radiating down from the hip itself. So typically, again, mechanical pain when you're walking in the groin, but also often the tipping point for people is when the pain starts to wake them up at night. And typically pain that's waking up at night interferes with your quality of life. You just can't live like that. The surgery takes about an hour. It's normally performed under a block or general anaesthetic with a block. There are different approaches to replacing the hip. You can either go through the front, the side or the back. There's various advertisements around for different approaches to the hip, but basically all of those approaches have been around for decades. The replacement is performed with implants similar to these. So you have what's called a modular replacement, and the titanium stem coated with hydroxyapatite, a modular head, and then a cup as well, which is metal backed, porous ingrowth back, and then a shell which is high molecular weight polyethylene. There are some variations, much more so than knee replacement, for instance, in terms of what sort of materials you can use for implant bearings, especially in hip replacements. There's a complication rate of about 5%. There's certainly, as with all implant surgery, we're paranoid about infection, but there's still about a 1 in 100 chance of infection. And again, if the implants get infected, that can be disastrous, and you might need to have everything taken out and start again from scratch. That's called a 2-stage revision replacement. After hip replacement surgery, you can get a deep venous thrombosis. I would put you on some blood thinners after surgery for 30 days, just an oral blood thinner. And also when you wake up, you'd have calf pumps to reduce your risk. But despite this, the risk of getting a clot after a hip replacement is about 10%, 1 in 10. There is a 1 in 1,000 risk of fatal pulmonary embolism after hip replacement surgery. There's also some risks in terms of the technique that's used. There's some nerves are at risk depending on which technique you use, front or back. There's different nerves at risk. About a 1 in 300 chance of damage to nerves or vessels, major vessels around the hip. And in particular, the vessels behind the acetabulum, so the cup component. If we need to put screws in that component, there are vessels, deep vessels, very large vessels inside the pelvis that may be damaged, but that's very rare. The other thing that you need to be aware of is that the head we put in is much smaller than the head we take out, and because of that, and that's to reduce the wear in the component. So in order to reduce wear, we need a smaller bearing because that lasts longer. So because the head is smaller, the risk of dislocation, if you can imagine that moving around compared to a big head, the risk of dislocation is slightly higher than for a native hip. Surgery typically is reasonably well tolerated. So you may have some bleeding around the wound after surgery. Again, there's a balance between the blood thinners we give you and to reduce the risk of clotting, and those blood thinners also increase the risk of bleeding. So you may have what's called a hematoma after surgery. That's reasonably common after hip replacement surgery. You will have a drain in typically if I operate on you for hip replacement. The drain comes out day 1. You will have a urinary catheter in. You'll be reasonably bedbound the first day, and then you'll get moving. Around about day 1, you'll take a few steps. Day 2, you'll be reasonably free to move around the cabin. You'll be in hospital for 3 or 4 days typically. I normally recommend that you use crutches for 6 weeks. Most people feel that they can get away without crutches for much sooner than that. Because hip replacement is such a successful operation, there have been various people trying to market themselves in that area, and that tends to produce some probably misleading information. There are different approaches, as I mentioned earlier, to doing a hip replacement from the front and the back, and the approach to the front has gathered a lot of attention recently as being a quicker stay operation in terms of getting better quicker. The other main controversy is in terms of the bearing surface. So a few years ago in the Australian media there was a lot of controversy, or a lot of publicity I should say, around the use of metal against metal components. So That means that the socket was actually metal as well as the bearing, and that produced a high level of what's called metallosis, so metal particles being shed into the bloodstream and into the surrounding tissue with all sorts of complications. So metal on metal bearing replacements largely is not very popular, I should say, afterwards. There's still some indications possibly for doing it, and those implants have been around for a long time. I think that particular implant unfortunately had a very high level of metal wear associated with it.